Welcome to the Special Operations Medical Association podcast series on prolonged field care. Any opinions contained in these podcasts are those of the authors alone and do not reflect U.S. Army, DoD, or U.S. government opinion or policy.
Welcome back to the Prolonged Field Care Podcast. This week we're going to continue our Crush series with part 2 of 2. This time we're going to have a roundtable discussion with Doc Riesberg, myself, Dennis, who is an instructor here at the JSOM-TC, and Eric, who is an instructor at the SOCMIS course. We're going to go over the questions, answers in the poll, and then we're going to go and talk about a little scenario that we have set up about a crush injury. Be sure to check out our blog at prolongedfieldcare.org. Enjoy the show.
All right, well, this is exciting to me, I think, because one of the reasons we threw this out to the big researchers and everybody else was medics all the time have questions about crush. And I think it's a surrogate injury for a lot of other injuries. When we think about prolonged evac times with tourniquets on, you can apply some of these same principles with what's going on in crush to other types of injury patterns and think about what's going to happen with the physiology. So that's pretty exciting. The other great news is we've had great progress with the Prolonged Field Care Field Clinical Practice Guideline, working with the U.S. Army ISR, the Institute of Surgical Research, and really appreciate all their efforts on that. And I think it confirms some of the stuff we have talked about for the last year or two, which is there's a lot we don't know about crush, and there's not a lot of good evidence on many of the things that we hold as dogma or regular treatment. Examples would be sodium bicarb. Does it really make a difference? We don't have good evidence for that at this point. But that being said, we got to go back to what's an average guy got in his bag, and let's see what we can do with that.
All right, on that, one of the first questions that comes up is the fluid resuscitation. The treatment of crush injury primarily surrounds A, fluid resuscitation, B, treating acidosis, C, treating electrolyte imbalance, or D, correcting hypoxia and oxygen debt. Of all of those, we had 12% say fluid resuscitation and a minority say treating acidosis as well as treating electrolyte imbalance. The fifth choice was all are correct right there. So everybody, 77% picked all are correct. What do you have to say about that one?
Well, my hat's off to you if you can treat all of those at the same time. So, but truly, this is a great question, and I think as you're triaging, take a worst-case scenario for crush injury. Chances are you're going to have more than one patient. So I think the very best a medic can do is start thinking in terms of, all right, what interventions can I get on board right away that are going to make a difference? The answer to that is very simple: fluid resuscitation. We got to get those kidneys perfused, maintain that urine output, and prevent the onset of acute kidney injury. Fluid resuscitation, choice A, is the way to go every time. Now, those other answers aren't incorrect. Those are all factors that we're going to look at as the crush injury evolves over the next 24 to 48 hours. But what's going to help you and help your patient right away is get those fluids on board. Crystalloid resuscitation.
And it seems on question number 5 that most people got that one right as well. The question was, what is the fluid type of choice when treating crush injuries and are trying to clear the kidneys of myoglobinuria? We had fresh whole blood, 5% answered that one. Colloid, like Hexten or Hetastarch, only 1%. Crystalloid, lactated ringers or normal saline at 80%. And then hypotonic IV solution, we had 11% there. So what's wrong with hypotonic IV solution or a colloid?
So this is a great question because this gets back to really the pathology, and the pathophysiology of crush. So what we're looking at is, if you remember back when you were studying the kidneys, there's those little tiny arterioles going into the glomerulus. And as those arterioles go in, we know there's a couple problems in crush. And those little guys, the afferent arterioles, narrow and they become a choke point. When that happens, your kidney's ability to filter electrolytes is compromised, and we also know at that point you're also going to have all the other muscle pigment, all the other bad stuff that's floating around in the circulation from the damage of the crush injury. So that's why fluid's so important. We want to open up that narrowed afferent arteriole, really flood that sucker, force that guy wide open, and allow the kidneys to do what they do best, which is process electrolytes. The reason we don't want to choose any of these other factors is we need to get fluid intravascularly quickly on board. A volume expander, traditionally as we think of Hextend, you're stealing from the cells in order to expand that volume. So not the ideal choice. It's good to see that a small percentage chose that one. Fresh whole blood, this is an interesting concept because if a patient had a concomitant trauma, that may be an appropriate answer if they had some type of hemorrhage. So that could be correct depending on the situation. But again, I would say if your primary injury is the crush and that's really what you're trying to mitigate, crystalloid is going to be the way to go. Why is hypotonic bad? That's a great question. So think about that one for a second and think, so I'd throw that out to the medics here at the table. What do you think? Why is it bad? Why would you not want to use a hypotonic solution?
I think you're going to lose that intravascular volume. It's going to go out in tissues, create more edema, more pressure, more ischemia.
There you go. Exactly. So really we're going with the tried and true, and I would say there is limited evidence, but enough studies to show that really normal saline is the soup du jour as an isotonic solution. And we could argue about that. There's some nephrologists that would say Plasma-Lyte is probably a better choice. Why would you not choose LR? Again, theoretic risk because of the potassium in the lactated ringers. And you're already going to have issues with potassium. So those are the other thoughts on that.
Sounds good. We'll go right to the next question. In non-crush injuries, we look for a urine output of 30 to 50 mLs per hour. How will this change in crush injury patients? A, it won't. Urine output should stay the same at 30 to 50 mLs. B, increase urine output to 100 to 200 mLs per hour and watch for signs of pulmonary edema. 50% picked that answer as most popular. And then C, decrease urine output to 15 to 30 mLs per hour and monitor for hypovolemia. The last answer was urine output is not a reliable vital sign in crush injured patients. The right answer here was increase urine output to 100 to 200 mLs per hour and watch for signs of pulmonary edema. But this is where the controversy online came from right here. So let's delve into this one a little bit.
Yeah, so this is an interesting question. I think probably the controversy relates to, are you fluid overloading a patient who's already got renal compromise? And this is one that you'll see nephrologists argue about, and this is where it comes down to some of our core prolonged field care capabilities. Really monitoring your patient and getting a sense of what's happening with that patient. So if you're watching their urine output and it's been doing pretty well and all of a sudden it starts to drop off rapidly, despite the fact you're still using aggressive fluid resuscitation, so in excess of 300 to 400 mLs an hour, and that fluid starts to drop off, you might be facing oliguria or maybe anuria, so lack of urine production due to severely damaged kidneys. At that point, you would turn your fluids off or reduce your fluids because all you're going to do is flood everything else. Lungs, brain, organ beds, abdominal compartments. I mean, you're basically going to make a problem worse because the kidneys aren't clearing the fluid. However, if the reason the reduced urine output is due to the fact that you're not getting enough in and the patient responds favorably to an increased rate of your IV fluids, then I'd say you really want to shoot for that 1 to 200. And that goes back to that afferent arterial concept that we talked about before. We're flushing out all the bad junk that's in the body and we're providing good support to that afferent arterial, keeping the pressure up so the kidney can do its job and prevent injury.
On that one, common question I get asked, okay, say I'm getting good urinary output, he's starting to kind of clear up, myoglobinuria is starting to decrease, his urine starts to clear up. At what point in time do you stop?
So my question to you would be how much fluid you got? Because, so think about this, if we're running pretty high fluid rates, and chances are, again, you're going to have more than one or two of these patients, how much crystalloid do you have on your loadout? So that's going to determine that. The medical answer seems to be 48 to 72 hours for that ongoing IV support, and that gives the kidneys time to recover and get back to function. Now, here's what I love about our guideline and something that Doc Powell has thrown around. What's wrong with just letting them drink if they can drink? Or, worst case, a rectal infusion where you're supporting them through another means to get that volume on board. Nothing wrong with that. So my thought is, hey, at least give them 24 hours, make sure they're peeing, and then gradually turn those fluids down and make sure they're still peeing, And if they're able to start drinking at that point, get them off the IV fluids. Again, resource constrained, right?
All right, next question. Renal damage can result from blank of muscle cells from crushing injury and releasing the cellular content into central circulation. We have rupture, dehydration, edema, excitation, or E, all of the above. What do you guys think?
I think it's pretty clear. The problem with kidney injury is the stuff that's inside the cell comes outside the cell. So either through dehydration or edema, the cell isn't destroyed. Only ischemia or actual physical destruction of the cell is going to release those contents.
I think it's a great point, Dennis, because there's two mechanisms causing that, right? You're getting the direct physical trauma of the crush that's crushing the cell, but what else are you getting that's damaging the cell? You're getting lack of blood flow, right? So if we think about our tourniquet and the fact that all these cells are now anoxic, they're being deprived of life-saving blood to support them, you're going to get some derangement in cellular lysis there. So both from the physical direct trauma of the crush, but also from the vascular compromise, not getting blood flow. You got two hits there that are going to create a lot of bad cellular contents in the circulation.
That's one thing I found with a lot of students. They see the low percentage natural disasters where you're really going to see a lot of most commonly your crush injuries. So a lot of medics seem to think that, oh, well, it's like 0.01%. I've never seen it, don't know anybody that's ever treated it, so I'm not going to worry about it. But one thing, kind of like you're talking about with the tourniquets, that I always try to like bring up is you got that tourniquet on, whether it's like a junctional, AHAT, or just a regular extremity tourniquet, and you're in that prolonged field care setting, you're in the middle of the Sahara Desert, it's been a couple of hours, and now you're able to convert that thing down, ligate a vessel or what have you, trying to impress upon the medics that you're going to have a crush syndrome to some varying degree. And I think that's one thing a lot of medics need to kind of get in their head and start thinking about, because it's not just that building collapsing down on a patient. It's just your simple medical interventions that can cause this.
Yep, and that's perfect. That goes right into the last question of renal damage can result from ischemic injury due to what? And we have long tourniquet times, hypovolemia, compressed vessels, or compartment syndrome. And then we had 82% of the people pick all of the above.
I think so just like we said at the beginning, one of the things with crush is there's not a lot of data out there on some of these treatments. So bicarb is an example of that. But I think we're going to see a little bit more research going this way just because of what Eric just shared with us, tourniquets. So I think we're going to see data crossing over as we study tourniquet times and the resulting what's called reperfusion injury. When you release that tourniquet and let all that deoxygenated, all that toxic metabolite accumulation back into the circulation, what happens and how do we best mitigate that? Right now, we're thinking you do what you do with crush. You fill the tank, you flood them, you keep the kidneys rinsed, basically. But there's a lot of discussion over bicarb. How much does it help? Well, my thought is this. There's no studies that show harm on that, and so I think that's a big part of our guidelines. In addition, I think most guys are carrying at least a little bit of bicarb, and it's easy to make. You can pull 250 mLs out of your 1 liter bag and put 3 amps of bicarb in there. That will be a hypertonic solution if you use a normal saline, but if you got some D5 floating around, D5W, pull those 250 out, put those 3 amps in, that's perfectly isotonic, and you're going to alkalinize the urine. Run that at 150 mLs an hour. Great stuff. Again, not a lot of evidence for that, but we use that all the time in the hospital for TCA overdose. We use it for contrast nephropathy. So radiologists don't like giving patients CT scans if they've got kidney issues, so renal failure, acute or chronic. But if you can get those kidneys washed out with that bicarb regimen I just talked about, a lot of times they can go in, get a CT done, and not take a hit to the kidneys at all. So we have some studies that show that that's probably efficacious. We just haven't extrapolated those to crush fully. Trying to think, were there other things you guys saw on that upcoming CPG that might stand out?
The one thing that stood out to me is just, there's Kxalate, there's all these other meds on there. The medics asked me, like, should I really order all these? I have a limited budget. What should I really take when I'm going on a deployment?
It's a great question. So, and I'd throw this back to you guys. What's the stuff you're already going to be carrying? Well, albuterol is a no-brainer. I think everybody's going to have that. We know the effects from albuterol are pretty short-lived. We're not going to get a lot of bang for our buck on that, but it's something you got in your aid bag that you can treat a lot of other things with. So I think that's a great primary drug to think of. Sole purpose, drive those potassium levels. So intravascular potassium levels down. You're just driving that potassium back into the cells to help the kidneys out. So that's good. K-Exolate, this is one we talked about a lot. That's the only proven way to get the total body potassium down, right? But downside is I don't know anybody that's carrying K-Exolate, and I'm not even sure you'll be able to pick it up at a pharmacy. But it's there, and you know, it's an option if you can get a hold of some. Most hospitals have it. And even community hospitals. So depending upon where you're at, you could probably scrounge some up.
With the K-Exolate, can't remember exactly. I think it was one of the MCRIT podcasts. They were talking specifically about K-Exolate. One of the things that was mentioned, he was talking about the actual study for the FDA approval for K-Exolate. They were already mixing in with insulin and glucose, which is probably one of the best treatment regimens for hyperkalemia. Some of the downsides I know that I've read on K-Exolate causes concretions in the bowel, which is going to increase more stuff you got to deal with. Going back on the sodium bicarb, I know out of all the docs I've spoken to about how it actually affects on driving that potassium back intracellularly, that's kind of debatable at best. About half the docs will give me different answers. But one of the biggest things I've heard on the sodium bicarb is that as it decreases acidity in the urine, in acidic environments, the myoglobin likes to break down and ferrihumate and agglomerate, and that ferrihumate clogging up the renal tubules, driving down into that renal failure. Is that correct?
Absolutely. So when we think of it from, and there's numerous things where we're trying to quote unquote alkalize the urine, and there's a lot of effects. Those are two of several. Again, we don't have studies to support that and say that bicarb, man, that's your mainstay in crush. That is not the case. But like I said, it's something that guys are carrying, and we do have a lot of experience with other acute renal insults where bicarb is at least helpful. And again, do I think it's going to hurt the guy? No. And are most medics carrying it? I think yes. So I think that's a great point, Eric. The other one I'd come back to is insulin glucose, insulin D50. Great treatment regimen, but man, insulin's got to be refrigerated.
Mm-hmm.
So this goes back to some of our discussions on RSI, and that hey, why aren't guys carrying succinylcholine around? Well, refrigeration, temperature control issues. Insulin is the worst among that. You got to keep that stuff tightly controlled in the refrigerator. So again, if you can scrounge it up and get it, that's the way to go, and it's easy to do. 10 units of insulin. AMPA D50, boom, right there, and you're going to drop that serum potassium pretty significantly. Let's say you're treating a crush patient, Eric, Paul, any of the medics here. You're treating a crush patient, and you happen to have your monitor with you. You don't have lab capability. You're monitoring this guy. It's a prolonged extrication. So crush scenario, under a building, a ton of concrete, and both lower extremities are crushed. You're starting to extricate this guy. You got heavy equipment. They're pulling the concrete off, and you're able to start restoring some circulation to that limb. You've got a monitor hooked up. Let's just say you're able to do a 12 lead, and you start noticing peaked T waves, changes in the PR interval. So that serum potassium's going up. What are you going to reach for first? What do you think in your medic brain at that point that you're most worried about, and what's going to be your primary treatment?
Well, assuming that I've already got fluids on board and they're rolling in.
Good call. I like it. Get those fluids going.
My first thing I would be thinking about, I need to protect the heart. Is we keep talking about kidneys for crush injury, but if his heart stops, then it's over. So we need to get calcium glutamate or calcium chloride. We need to get that on board first. We need to protect the heart. Then we can sort out the problems with the kidneys. Now there's a risk with that, I think. Giving somebody a dose of calcium, after you follow that calcium up, I would run another line, secondary line of my bicarb drip to try and keep the kidneys filtering that stuff out, alkalinize the urine. It doesn't have to be 7 on the pH. Just get it 6-ish, and it'll keep flowing.
Paul.
Yeah, so one of the things that medics are always going to bring up is, what about just throwing a tourniquet on it?
There you go. Because this is one that I think has been a change in our thinking as
Mhm.
we've thought about this problem and involved some experts over the last 6 months. And obviously, we go back to our March sequence, and if as you're extricating the patient, you think you assess there's an arterial injury and you're going to have massive hemorrhage, obviously at that point, I'm applying my abdominal or wherever I can get proximal control to prevent that hemorrhage. If I'm pretty sure, hey, our arteries are intact, let's go ahead and start extricating this guy. The general consensus seems to be throw the tourniquet on if you can.
Mm-hmm.
The idea being, hey, because when you pull that object, whatever it is that's crushing the patient off, they may start bleeding profusely at that point. My thought is if you're able to get the IV access, and I think in a lot of scenarios you can. We've seen numerous case reports with building collapses, other things in less developed countries where rescuers are able to start a line prior to extrication. If you got that on, you're not going to hurt the patient by throwing that tourniquet on if you're pretty close to extrication. So I think that's probably the best approach. Get the tourniquet on, get proximal control, remove the object, get the patient out, and then work with what you got. This is where it's a cool injury, only from the standpoint of we're thinking a bunch of different guidelines. So tourniquet conversion now, as we get that guy out, and we're going to convert that tourniquet, and we've got good guidelines for that. And now we're thinking, all right, what are we going to do with the physiology of all this reperfusion injury?
Okay, at this point in the podcast, we're going to go ahead and switch gears. I'm going to narrate a scenario, and then afterwards we're all going to discuss it. During our last deployment, we were tasked with training local police in vehicle mobility. The original house we were using must have been around forever. We didn't have our engineer sergeant out with us at the time that the building was put up, and didn't know if the house was rated to hold the weight of the large water tank on the roof. One night, we all woke up to a loud crash and screaming. As we scrambled to make sense of what had just happened, we found Josh under a pile of debris as he continued to call for help and grunt in pain. I was on the other end of the building and grabbed my aid bag. As I made my way through the rubble, I clicked on my headlight and crawled over to where his screams were coming from. His abdomen, torso, and arms appeared uninjured, but his legs were not visible. Josh was in the worst pain I have ever seen anyone in. I gave him 100 milligrams of ketamine IM, which wasn't as effective as I hoped it would be, and started a ketamine drip before the initial dose wore off. He didn't have any respiratory distress besides the dust, so I gave him 2 milligrams of midazolam as well. His right tib fib was clearly broken, and I had someone splint it. It was at this point that someone started to manage the scene and worry about secondary collapse. Some shop lights were brought in and set up so that we could properly assess the situation. Our team leader started making calls, the TSOC, the B team, etc. The 250cc bag of normal saline I had running wide open quickly ran out, and I switched it for a 500cc bag of LR. I knew the longer he was trapped, the worse it would be when he finally got him out. We didn't have a crane or a winch. After about an hour of running around, someone finally thought of drilling a hole in the bottom of the tank to let the majority of the remaining water out. The iron supports and muddy bricks were still pinning him down. I knew he was probably going to need a Foley, but didn't want to do it in that ridiculously dirty environment. At this point, I had given him nearly 2 liters of LR, and I knew he was probably going to pee soon. I emptied a Nalgene and put it where I thought it would catch his urine if he did go. I had also started up some Invans IV. I also hooked up the new Tempest monitor with the 12 lead. We hadn't figured out how to network the vitals back to a receiving station yet, but could email pictures of rhythms. By the time we thought we were ready to jack the mangled iron off his leg, he had been trapped with his leg crushed for over 3 hours, and I had used roughly 4 liters of fluids and 600 milligrams of ketamine. I organized my notes and called the virtual critical care consult. All right, so what do you guys think about that situation?
Well, it's good you got the monitor and everything else, because without the ability to do labs, that's going to help you out, at least in terms of life threats for this guy. If you're starting to get your potassium's creeping up, you'll be able to watch that live time on that Tempest and be able to shoot some serial EKGs. Hopefully, if you can shoot those images via email, the critical care guys can back you up on that too and provide you an overread. So that's good. You got that in your favor. Flip side is, I guess the question would be, they're going to want to know how much fluid you got. Can you actively resuscitate this guy? Do you have enough crystalloid? So,
Yeah.
I also think it's important, with a topic like crush, so everybody's focused on the crushing injury. You gotta keep in mind the basics, the ABCs. You gotta make sure you can still breathe, because it was a building collapse. He might be in one position now, but there's nothing to say that that whole building hadn't shifted off of him and is now just sitting on his legs. So it could have been You may have a chest injury, you may have a pelvic injury. If we're just focused on what we see now, we might be losing him. So we gotta make sure he can breathe, we make sure he's not bleeding anywhere else, make sure he's staying warm. That whole lethal triad stuff, it definitely applies. Just because the scenario says crush doesn't mean other things are happening too.
Great point.
So in regards to the monitor, I know one thing, several sources I've seen, they talked about that there's classic peak T waves, widened QRS, disappearing absent P waves. Those signs on that monitor have a high specificity but a low sensitivity.
You got it. They're specific, right?
Mm-hmm.
So if you do see them, you know you got to make an intervention. So that's good. But if you're not seeing them, it doesn't mean that you still shouldn't do the intervention, right?
Yep.
So just because it's not there doesn't mean, hey, this guy's good to go and you can just run the fluids. I would still consider, if you have the calcium gluconate, running some of that, because again, you're not going to hurt them. In the back of your head, you're thinking hyperkalemia, this is going to be the thing. Aside from, like you mentioned, Dennis, that's a great point, other life threats. How's this guy's temperature? Let's go back to a full reassessment. Does he have a pelvic fracture with a slow bleed, intra-abdominal or an intrapelvic bleed? So, you're thinking about all those things as well. But yeah, it's a great point, Eric. I would say whenever we got a high specificity test, it's still worth doing, but you need to be thinking in the back of your head, hey, this could still be going on, even if it's not showing up on the EKG. But if you see it there, at least then you know for sure, man, I got to fire for effect right now, get that calcium gluconate on board, and be thinking about a potentially fatal dysrhythmia. So hopefully have those pads nearby and be ready to defib.
So I know not a lot of medics are taking an iStat with them just due to the prohibitions of the cartridges and the glue and everything that go along with them. When would it be worth it to go get a blood sample and maybe run it to a local lab, a host nation lab?
If there was a scenario, this would be it right
Yeah.
here, just because that prolonged evac. So I'm thinking about that scenario you just gave us, Paul. That's a great one because this guy has already been in there for 3 hours. You've already used 4 liters of fluids. So you've already changed this guy's basic serum electrolytes quite a bit just through the use of your isotonic saline. We know that after 2 to 3 liters, they're going to start getting a little bit of that hyperchloremic acidosis. So you've already got some of that going on, but you're keeping the kidneys perfused. At this point, I'm wanting to know everything from what's this guy's sodium level, what's his potassium. So a simple basic metabolic panel that many hospitals, even in developing nations, can run. A simple BMP in this case could be life-saving. That could be great information for this patient.
Now, how often should you try to get lab values and lab samples like that?
I don't know. So that's going to be MET-TC for sure.
What if you have a 30-minute turnaround to the lab and back, and then obviously they're going to have to run the labs as well.
Right.
So it would take some time, but if you're going to be there, a couple days till you get this guy back to definitive care.
Yeah, so this goes back to Eric's question, how long are we running these fluids? And I'd say if you're planning for at least 24 hours of fluid, IV fluid resuscitation, you probably want to be checking these labs in a really constrained environment where it's a pain in the neck to get those labs, at least every 12 hours. But if you could do it every 6 to 8, especially in a case like this where he's got a pretty significant injury, that's going to help you out. But at a bare minimum, every 12, so you know you're not getting way off the reservation.
Several units are rolling around with the rapid lactate monitors for threshold blood. Is there any correlation between lactate and potassium by any stretch of the imagination? Just as something, if you don't have that local clinic, you're out in the middle of the Sahara Desert, and that's your only diagnostic lab tool.
I don't know. That's a good question. But we do know because think about how lactate is produced and what that's a measure of, right? So we're using it as a measure of ischemia or shock, right? So basically you've got a crushed limb or crushed body parts. So basically those have been in shock. So the lactate may not tell you where your potassium's at, but it could give you a gauge of severity of the crush injury.
Mm-hmm.
We don't have the data though, Eric. So there's no studies comparing that yet. But hey, if that's what you got and that's the only lab device you got, heck yeah, man.
Mm-hmm.
I would trend that every 2 hours and monitor those lactate levels, and that actually really could help guide your resuscitation, especially in taking with your urine output and throwing that 12-lead monitor on. And if you're noticing this patient is trending towards oliguria, anuria, and is not responsive to your fluids, at that point, again, I think all you guys you're shaking your head here at the table. We all know it's time to turn the fluids down. And then you're going to go do a full clinical exam to look for signs of fluid overload. So pulmonary edema being your big one. At that point, what we know from the medical studies is Lasix really may or may not work. And if you do get some response from it, it is not going to be therapeutic. It's not going to fix the kidneys. So don't be fooled into thinking urine output as a result of a Lasix administration is the kidneys are working again. That is not necessarily the case. An anuric patient needs one thing, and that's renal replacement therapy, or basically dialysis. So at that point, this is far beyond our powers in the field, and that's going to be a fly faster type of scenario. If, however, you're trending and maybe they go anuric for an hour or two and you're able to start seeing a whiff of urine production again, then you're really going to have to titrate your fluids carefully and listen to those lungs. Careful examination to make sure you're not fluid overloading this guy. Abdominal exams, again, looking for that abdominal compartment syndrome, all the other signs of volume overload. If that's not the case, then again, try and prioritize that kidney treatment and get those kidneys back. Tough one.
One of the things that I wanted to say on that is just doing those serial physical exams, so listening to the lungs and then writing down what you find. You're doing that every 6-8 hours, you're going to notice a difference once you've done that 3, 4, 5 times.
Yes.
So you can write that down on the training sheet and then track your own progress, because you're probably not going to remember, oh, what did I do 4 hours or 24 hours ago? But if you write it down on the sheet, like, okay, lungs were clear, or whatever else that you're doing, whether you're palpating the abdomen, that's going to be clear indications as well. And what are some other considerations that we have to think about? We have fasciotomy, infections, and then, like we already mentioned, the pelvic injury. What are some other things that we have to think about there?
So that's a good question. Would you guys throw antibiotics on if there were no open injuries? So let's say this guy got really lucky, totally crushed extremity, but it's closed. There is no break in the skin at all. Would you put antibiotics on board, recognizing that certain antibiotics, because of renal clearance, are going to stress the kidneys a little bit more?
I would say no.
My thoughts on it are, this guy's probably going to need a fasciotomy. If somehow it's still closed, you're going to have to cut him open.
Mm-hmm.
You should have antibiotics on prior to cutting him open, maybe an hour before. So I wouldn't maybe go ahead and give it, 6 hours before, but if you get him on an hour before cutting him open to do the fasciotomy, it'd probably be good.
Yeah, I agree, Paul. I think real world, it would be very rare to have the type of injury we're discussing without some sort of even pinpoint portal of injury. Yeah. And the countries in which we do business, we know, whether it's spore formers in the soil or other fungal elements, it's just endemic. So it's just a matter of time until the infection gets on board. So if there's any open injury at all, absolutely, get the antibiotics going.
Yeah, absolutely. So, just for the sake of making everything worse, say you start to hear crackles, maybe your SpO2 monitor the numbers are starting to go down. We think he's fluid overloaded.
So, man, you just want to make this a bad day, huh, Dennis? So my first, again, I tend to think from least invasive to most, mainly just because you're trying to control risks here. And again, we know that you could try some Lasix at that point, but I don't think you're going to get any response. Because think about how Lasix works. Loop diuretic, loops are bagged. They're obviously damaged to the point where the patient's anuric. Really, you're spitting on a fire with pharmacotherapy at that point. So go to where the money's at. The issue is in the lungs. It's a volume overload problem. You have a great tool in the form of positive pressure ventilation that you can use for that. Unfortunately, that's going to depend on what you got in the field or what you can rig up. Now, we've done some experimenting and rigged up a SAVE vent with a CPAP mask to provide a patient positive pressure ventilation. The idea being basically anytime they breathe in, boom, that thing gives them some nice positive pressure. Throw a PEEP valve on there, keep those alveoli recruited, distended, blow some of that extra fluid out of the lungs. So positive pressure airway ventilation would certainly help you, and something where you're not, again, going to add to the mix of already bad issues with the kidneys.
So usually, like, the PEEP valves are set at 5.
5, yeah.
Random number 5,
Yep.
or what we figure is good. What kind of criteria would you want to use if that's too much, because too much PEEP, you can inhibit hemodynamics. Too little PEEP, you're not going to get what you want. So what kind of criteria would you use to set your PEEP value?
Well, shoot, Dennis, you just answered your question right there. It's a great one. It's a good question. Start with 5, and in vast majority of patients, that's going to be effective for you. So 5 of PEEP, and what you're going to notice is pretty quickly you're going to see either improvement in your oxygen saturations, or if your PEEP, say you are tweaking it up a little bit, and you're trying to get those alveoli dried out and recruited. And again, we're speaking, kind of in gross terms here, but dry those alveoli out, get them inflated. But you're overinflating, you're going to start seeing some blood pressure changes, maybe some other vital sign changes. So keep an eye on that. Watch your pulse pressures, obviously, your difference between your systolic and diastolic. You may see other indicators there. But again, you're going to be watching your vitals really closely at that point, since this was a patient that was starting to have respiratory distress. That's going to be your primary life threat at that point. And then again, we'll get back to the kidneys once we get the cardiopulmonary stuff worked out.
Would you also want to consider like patient positioning, nebulizers, albuterol?
The albuterol, probably not. Positioning, absolutely. We know the lungs, various ARDS trials have shown that proning or positioning the patient, changing them, improves blood flow to the area. So I don't know if there's trials showing that as a treatment for pulmonary edema. That's a great question. We can throw that out to our audience and maybe they can hit us back. But it makes sense intuitively. It works well with ARDS to prevent ARDS, or also help with treatment. So yeah, moving your patient around, trying to get that additional recruitment and reduce that pulmonary edema. Good call. And again, it's easy to do, fairly easy.
Number of classes ago, I had a PJ who's down in Haiti doing a lot of the rescue efforts there. By and large, the vast majority of those patients, it was just body recovery because they'd been buried for days. One case he brought up was they're going through and they found this woman under a bunch of rubble. The only thing they could see, she's completely unconscious. The only thing they could see was her buttock area. Don't have a good vessel to start putting fluids on and try to get her to come back to push the sodium bicarb, all your drugs and everything. Is what they wound up doing was 10 cc IM injections until she started regaining consciousness. It eventually worked. Couldn't remember exactly how much they wanted pushing, but it was about 15-20 minutes in between. And she started to regain consciousness, and it still took them another 6 hours. So if you were, say, in that position, you're able to get the IM fluids, not the best, and it's the only site you have. When you start looking at the drugs, I know it's not ideal to push any of those IM. What is your take specifically with the calcium to really try to protect the heart so you can at least get this patient out underneath all the rubble and then gain access, good vessel access, and start pushing those drugs?
Man, that's a tough one, Eric. Well, first off, I'd say, so we have, going back to the fluid resuscitation, I think you've got other options before the IM. I'd question, hey, maybe it was the pain of getting serial intramuscular injections with 10 mLs of fluid that actually revived this patient. She just became pain responsive on her AVPU scale. But certainly at that point, you would think about a rectal infusion. And there's a great Wilderness Medicine article that describes how to do that, even has pictures of how to rig that system using a glove tip. So supplies that everybody's got on hand, and you can do a rectal infusion. You just want to make sure that infusion is isotonic, so mix some Cerolite or whatever solution you have with some salt and a little bit of glucose in there. Rectally, if she's still got that area is not compromised, she's going to absorb a lot of that fluid. That would be my primary treatment in that case. I would not, and at that point, you could also consider upping some calcium in that rectal fluid because it's going to absorb. So I would steer away from the IM, only because just like we've learned the last 14 years of conflict with morphine, man, IM is a bad way to go. It can pool, and then you can have a vasodilation, and then all of it hits the circulation as a bolus. IM is so unpredictable. And in a patient that's already renal compromised and challenged, it'd be a tough one to predict how they're going to respond. Tough case, but again, go with what you got. And hey, in that case, it worked out. But certainly a little bit of fluid is certainly